Next, then we'll come to the left side of the room.
Governor, earlier, excuse me, earlier you talked a little bit about the math that goes into finding the positive rate. Other states and other organizations like Johns Hopkins University, they do it a little bit differently. They do the unique positives divided by the unique tests. Why does North Dakota do it differently, and does that kind of give a confusing message to people?
Well, let me be clear first about the, as we've researched this a lot recently, it appears to be from the Johns Hopkins website, which of course is a well-respected brand in medicine, that they're using the data from a group called the COVID Tracking Project. The COVID Tracking Project is sponsored by a magazine, The Atlantic. This is not a government-sourced thing. So I would take a look and say, okay, if you're getting your information from a non-government source to make these predictions, that causes me some concern. We went back and pulled all the data from the beginning that the COVID Tracking Project, the Atlantic magazine COVID Tracking Project, was using from North Dakota, and we're going to pour through all of that to try to understand what, when they were pulling it, what they were pulling it. It's interesting. They're suggesting that there's things there that we're not reporting that we've been reporting from the beginning. So I think there's some data gaps, data translation, data issues between the COVID Tracking Project and the state of North Dakota, because between our office and the health website, others have said that we've had some of the best information, the best graphs, and the most timely information. We're doing it both ways. When you look at the footnote under Johns Hopkins, it says that states should report the number of individuals that are tested and the number of total tests. And we've been doing that for all along. And so if there's additional information, we walked through all the block and tackling today, but if there's things that we can do with the numbers that we have to make them more clear to everybody, we'll do that. But I guess I would say I disagree with the COVID Tracking Project from the idea that every time we test someone, because it's a point prevalence, it doesn't matter if we tested them last May. If they thought they had symptoms last May and got tested and they were negative, turned out they had a cold, they walk in the door and they get tested today and they're positive, then we can't count them in the denominator because we tested them once before, so we count them in the numerator but not in the denominator. If you were doing that in math class, I don't think you'd get a very high grade. I mean, so it's like if you're gonna understand the point prevalence, which is what all of our epidemiologists, whether it's Dr. Carson at NDSU or others, have all reviewed the way we're doing it. They all say this is the most responsible, the most transparent way to do this, is to make sure that when we're giving the daily rate, that we're taking every test we take today, because it doesn't matter if we tested them 2 weeks ago or 2 months ago. If they've got it today, they need to be counted in that denominator and the numerator. That's the point prevalence. That's the daily positivity rate. Cumulative rate, we agree. If we were counting every test that we'd made and trying to throw it in to artificially lower our number below 3.8, if we were trying to get it down to 1.9, what it is, because somehow we thought we would be advantaged that way, but that's not anything we've ever done. It's not anything we would ever consider. We want to make sure that North Dakotans have all the information they need about the tests that we're doing so that they can make smart decisions for themselves. And we're going to continue to fight for transparency and make sure we get all the numbers out there. So I guess I disagree with this idea that serial testing shouldn't be counted. And again, when we dug into that list we've used before of here's the top 10 in terms of testing per capita, I think there's a number of states above us that are including in their percent of per capita tested, they're counting people that they've tested twice. Rhode Island was number 1. Now they're down below us because Rhode Island started counting it the way we did. If everybody else started doing it the more conservative way the Rhode Island and North Dakota is doing, Rhode Island and North Dakota would probably be number 1 and number 2 on that chart again. But there's all kinds of issues with Washington, D.C. data, because they're including data from Virginia and Maryland in their data. So you just got to throw that one out completely, the District of Columbia data, and you look at the state data. But different states are reporting it different ways. We think we're doing it accurately, completely, transparently, and again, in the most effective way for anyone to make policy decisions. We'll go Jeremy and then Jack.
So I guess the way that Johns Hopkins reports positivity rate is based on a 7-day rolling average using only counts of unique individuals tested, as Lane mentioned. Why not provide that number in addition to the positivity rate that is provided on a daily basis, counting all of the tests taken?
Well, it's, and again, you're saying Johns Hopkins. COVID tracking project run by the Atlantic is the one that is producing that number. And if you take a shorter set of days, like 7 days versus 14, we've been doing 14 all along. We did 14 because it made sense. That's what the isolation rate was, right? For us to kind of match the sort of the course of this disease. If you were going to try to have, in the politics of data, if you're going to try to have a state that previously was very high, take any of those in the New York metro area that was high, and you want them to look better, you would use the shortest possible rolling average. If rates are trending down, then you'd have a shorter date. I'm not suggesting anything, that's just a math observation. Again, we're more conservative by using the 14-day rolling average. If somebody wants to take a look at the 7-day, I can tell you what the answer would be. If we had 7-day, it would have showed us looking better when things were dropping, and it would show us slightly worse now because it favors whatever direction or disfavors whichever direction you're going because it's not as long of a spread. But I don't have any reason why we couldn't show that number. From a policy standpoint, I'm going to keep looking at the 14-day because I think that gives us a better sense or a better trend. But again, Johns Hopkins is using the COVID tracking data. I think there's state-by-state comparison issues in the way that data has been being compiled. I mean, in a quick look at it, there was some data from North Dakota that wasn't accurate in there. So we're going to get directly with the Atlantic and make sure that make sure we understand what data they're pulling from North Dakota.
Follow up, that 14-day figure, where is that reported on a regular basis?
Well, it's reported here, and if that's something we need to post every day, if we're not posting that every day, I thought we were, but. Okay, well, thanks for pointing that out, Jeremy. I'll check on that, but it's, there's not, again, the data is all there, and I suppose somebody could compute it, someone could easily compute it off of what we put out every day at 11 o'clock, but if we can do the math and maybe we can include that on the daily report every day. Easy enough.